Thanks, Nick. Okay, we're going live. Let's just see who's here. Okay, so hello everyone. Good morning, afternoon, good evening, and thank you everyone for joining. We've been doing virtual MDT meetings since early 2020, just before COVID. But the meeting today is the first real tumor board with the pediatric oncologists, ophthalmologists, radiologists, and pathologists as presenters and on the panel. Thank you, Petra, who needs no introduction, but just to be formal. So Dr. Petra Ketteler is a pediatric oncologist from Essen, Germany. Petra moderated many of the Rb NET MDT meetings and will moderate today. And a very big thank you to all the panelists and presenters. A few housekeeping rules, so feel free to ask questions via the chat box or the Q&A box. You can use, I hope it will work, but you can use the captions feature and use your language of preference. I have, I'll just show this, just 1 minute. Let's see if this works. Can you see my screen?
Yes.
Yeah. Okay, so hopefully everyone has this button. So once you click this, the meeting obviously will be in English, and then you can choose your caption language. And we'll speak in English and you'll see the translation live. Okay. The meeting is recorded and I wish us all a successful webinar. Petra, over to you.
Thank you very much for the introduction, and good morning, good evening, good afternoon to everybody worldwide. A big thank you to Didi for organizing this meeting and the team of the Rb NET MDT in London. I'd like to introduce the panel. We have from radiology, Hervé Brice from Paris and Selma Zirin from Zurich. And also Pim de Graaf from Amsterdam. I think he'll join in a minute. And then we've got pathology experts. We have Geeta from India and Anita from Singapore. Hello, everybody. We will start with the first case from London. It will be presented by Ashwin Reddy as an ophthalmologist, Ulrike Löbel for imaging, Victoria Bryan from pathology, and Tanzina Chowdhury from pediatric oncology. Thank you very much.
Great. Can you see my presentation? I'll just go into the beginning.
Yeah.
Excellent. Well, thanks very much again for the invitation to speak, and thank you to my colleagues. Just to remind you, so I'm Ashwin Reddy. I lead the retinoblastoma service in London. I'm an ophthalmologist. We've got Ulrike Löbel, who's our neuroradiologist, Victoria Bryant, who's our pathologist, and we hope Tanzina Chowdhury will be with us at the end to give us the pediatric oncology input. So this is an 18-month-old girl with a shiny reflex in the left eye for 4 months. So thought to be an intraocular mass with calcification and elevated pressure by the referring ophthalmologist. There was no nausea or vomiting, and she's been rubbing the eye, that left eye. The other eye appeared to be normal on referral. Full-term baby, no family history of retinoblastoma with an older brother and younger sister. So as always, we dilated the parents, and there was no evidence of retinomas. So what did we find? So in the right eye, the pressure was 12, And in the left, the pressure was up at 36 millimeters of mercury. And at that time, because the pressure had already been at 40, the patient was on a hypotensive drop, AZAGA, twice a day. The horizontal corneal diameters were 11 in the right eye and 12.5 in the left, so enlarged ophthalmos. Right eye was normal, so we're dealing with unilateral disease here. And the left eye showed, as you can briefly see, vaguely, some abnormal vessels, new vessels of the iris, and ectropion uvei. So what did we see when we took photos and we had a look in? So we've got a pale mass, subretinal and exophytic. So we're not seeing many seeds. Dilated vessels that dive into the retinal detachment. And there were subretinal seeds and subretinal infiltrates with a total retinal detachment. So we performed an ultrasound, which found a calcific mass occupying most of the vitreous cavity with a height of 19.57 millimeters. So big tumor, really, in the vitreous cavity. There was calcification and acoustic shadowing, and the optic nerve could not be seen because of the shadowing. We define this as CT3C, group E retinoblastoma, in view of the ophthalmos and the neovascularization of the iris. So next, we asked Uli to form the neuroradiology. So Uli, if you want to comment.
No problem. So the first image is the axial T2 weighted imaging. You can see the tumor there in the left globe. The globe is also expanded, and there's retinal detachment with layering and fluid. On the next slide, this is just on the top, the T1 weighted image. That didn't add much in this case, but on the diffusion weighted image on the very bottom, on the left, you can see the tumor being low on diffusion weighted imaging, and you can even already see on this slide that there's extension of the tumor into the optic nerve head. On the slide just next to it, we do see again the enhancing tumor extending into the optic nerve proximally, and this was measured to be around 4 to 5 millimeters in length. The sagittal T1 up on top is just to show that there was no trilateral involvement. Also, the other eye was felt to be normal. And the axial there is just to show the optic nerve infiltration again. And the sagittal to confirm that there was no intraspinal extension. So in summary, we thought there was involvement of the optic nerve of around 5 to 6 millimeters actually was measured, but otherwise no extraocular involvement.
So we elected to perform an enucleation. We had a discussion at the MDT about the length, the amount of posterior laminar optic nerve invasion. And this is performed by my colleague Mandeep Sagu. And we knew that a long piece of optic nerve needed to be taken. So he cut the optic nerve with enucleation scissors for the longest length. And he actually went in again and took another stump, a bit of optic nerve as well. And he placed an acrylic implant 20 millimeters in the orbit. So now we go to Victoria Bryant, Dr. Victoria Bryant, who'll talk to us about the pathology.
Hello, everyone. So we're going to show you lots of pathology. So in this first slide, you can see that the eye with the upper and the lower culottes removed. You can see that the posterior segment is almost completely filled with tumour. And if you look closely, you can see little flecks of calcium throughout that tumour. So in the midsection of the globe, the optic nerve resection margin is inked in green, and we actually measured 6 millimeters of optic nerve received with this eye. And then to the far side of the slide, you can see the optic nerve stump that we received, and that was 3 millimeters in thickness. If you go to the next slide, please, Ashwin. So this is just a low power view of the tumour. Everything that looks sort of blue to purplish is viable tumour, and you can see it's growing around blood vessels, which look red, obviously, because they're filled with red blood cells. And all the pink areas are areas of tumor necrosis. So overall, throughout the entire eye, we estimated there was around 60% necrosis. And if you could move on to the next one, please, Ashwin. So this slide shows you the detached retina. You can see it's all folded over. But you can see within the retina that is where the tumor is originating. And we can see that in different parts of the retina. The next slide, please, Ashwin. And then this is just another view. So a little bit higher power, and we've got another focus of tumor elsewhere in the retina. So this tumor was multifocal, and you can see in this focus, you can see there are a few Flexner Wintersteiner rosettes. So we just had small areas where there was a bit more differentiation. And another thing to point out on this tumor is the basophilic staining of blood vessels, which we see quite frequently in retinoblastomas, and it's believed to arise from DNA from degenerating tumor cells, which for some reason sort of gets deposited in the blood vessels. If you can move on to the next slide, please, Ashwin. And there was lots of anaplasia throughout this tumor. So you can see in this slide, you can see scattered mitoses. So yeah, Ashwin's pointing those out for you. The more you look, I think the more you see. And then we've got all of these sort of large pleomorphic looking cells with lots of molding, and there's patches of apoptosis in there as well. Next slide, please, Ashwin. Then this is just to show you there was full thickness choroidal invasion. So you can see the sclera, the pink area to the side. And then there's sort of, it's like an artifactual space between that and the choroid that we do get after processing the eye. But the black-headed arrows show you the full thickness of the choroid, and that's completely filled with tumor. Also on this slide to the left, you can see areas of calcification, so all these chunky purplish areas. Next slide, please, Ashwin. Then here we've got a view of the optic nerve. So I've put an arrow where the lamina cribosa is. You can see the tumor at the optic nerve head, above that, and then below all of that blue is tumor invading the optic nerve. And you can see the optic nerve looks quite dilated as well, and the tumor's extending across the full width of the optic nerve. And then I've just circled near the inked margin, you can just see like a stream of tumor just traveling down. And then if you go to the next slide, please, Ashwin. And then this just shows the same on a higher power. So you can see those sort of crushed tumor cells all the way down. And next slide, please. So this is quite a bit higher power. This is from the optic nerve stump. So we took lots of levels through the stump, and there was this focus of crushed tumor cells just adjacent to the central retinal artery. Next slide, please, Ashwin. And that's just to show you on low power. So you've got the whole stump there, and that's what the picture looked like on low power. And then next slide, please. This is back in the optic nerve, and then this is just showing the tumor. It just extends right to the edge of the optic nerve. There was no tumor identified in the subarachnoid space, and we did look really closely at this. We had multiple sections throughout the optic nerve, and there was no invasion, but we were still concerned because of this tumor reaching up to the pia mater. Next slide, please, Ashwin. Oh, and then this final slide is just a nice slide of the iris to show you the iris neovascularization, which Ashwin showed on one of the photographs earlier. So the normal vessels in the center of the iris, you know, they're nice big vessels with quite thick walls. And then just on the anterior surface, which is arrowed, you've got these thin-walled vessels. We've got quite a nice picture here, a nice section going all along that vessel. So that's iris neovascularization. And next slide, please. So in conclusion, this was a poorly differentiated retinoblastoma. We graded it as a grade 3 because there were some focal areas with the Flexner Wintersteiner rosettes, around 60% necrosis overall, full thickness choroidal invasion and retrolaminar optic nerve invasion, and with tumour in the optic nerve stump. So the pathological stage for this was PT4.
Thank you, Victoria. And so this is the treatment. Is Tan on the call at all?
Yeah,
Excellent.
I'm just
Thank
here.
you, Tan.
Thank you.
So this is
Thank
the
you.
only slide I've got for you, so if you don't mind speaking about it, thanks.
Yeah, no, sure. So in view of that, and we'd already anticipated based on the imaging that she was most likely to need an intensive post-operative protocol with a Reto 321, which involves vincristine, cyclophosphamide, cisplatin, and etoposide. And there's an alternative to use carboplatin along the line if they run into significant ototoxicity. And she's had 4 cycles of that, or she's in the middle of the 4th cycle of that. So it's a sort of day 1 to 3 of all 4 drugs, and then vincristine at day 8 and day 15. And she's been prepared for proton radiotherapy to start in the next couple of weeks following count recovery. In addition to that, we would have done this anyway, but particularly in view of that concern about disease that may have escaped close to the arachnoid, we were giving her intrathecal topotecan and hydrocortisone. And yeah, oh, sorry, yes, I didn't mention the addition of sodium thiosulfate as otoprotection, which we were able to get on a compassionate basis because of the dose of cisplatin, and particularly in children with visual impairment, of course. So that's where we are with her. She's tolerated it as one would expect, tolerance of this intensive protocol. She has had significant vincristine toxicity from which she is actually recovering. But yes, nothing unusual and no significant morbidity for her on that protocol, but, you know, balancing, of course, the need to give her that intensity as we are treating her with curative intent, and therefore, you know, have to match the intensity of treatment to the extent of her disease. Thank you.
Wonderful. Thank you very much to Uli, Victoria and Tan for this. So that's the end of our presentation. Do you want me to leave the presentation up, Didi?
Get up for a moment. Thank you.
Oh, sorry, Petra, yeah.
Yeah.
Petra is the boss now.
The whole team.
Sorry, yeah, Petra, yeah.
Yeah, that's really a challenging case, and I'm looking forward to discuss the question. We've got a few in the chat already. So the first question is, how do you look for and resect the optic nerve stump remaining in the orbit after enucleation? So
Mandeep did this. I assumed what he did is he cut as far as he could, then he cauterized, this is in the operation notes, and then he found the optic nerve again, went for it, grabbed it, and then cut another piece off, and then cauterized again.
Thank you. Didi, do you have another comment? Because I know it's really difficult to find this optic nerve stump back, right?
It is.
I've never done that, so no comments on my end.
Yes, we very rarely do this. It was only because of the neuroradiology we've done that.
And the next question is whether there's a significance of the knowing about choroidal invasion before surgery as far as different management options are concerned. So I wonder whether that is regarding neoadjuvant treatment.
Tan, do you want to take that? Because we often have choroidal invasion, do we?
We do.
More about the optic nerve, right, than the choroidal invasion, or do you know? Go ahead.
Yeah, no, I mean, I think it's certainly something to consider. I mean, the extraocular protocol we would give, you know, we certainly could have given it in this situation, but there was also concern about the level of glaucoma that the child had, you know, raised intraocular pressure and the symptoms that she had. And also there appeared to be a sense that the optic nerve could be taken with a margin, which of course is extraordinarily challenging. And maybe in retrospect, we should have tried to treat her with neoadjuvant treatment in the first place. The choroidal invasion, difficult to assess on MRI. I mean, I like Uli's comments on this, but to what extent can you be clear regarding the thickness of the choroidal invasion? I mean, on MRI, in order to make it a risk factor or not, because until it's looked at from a histopathological point of view and you're looking at 3 millimeters or more, then it's difficult if that is your only criteria based on an MRI and maybe not with necessarily the sequences that are required, are you going to subject that child to neoadjuvant treatment unnecessarily? So I think it's a difficult question. I think if you've got other features that, you know, clearly extraocular extension, then you've got a case to argue for neoadjuvant treatment. But choroidal invasion alone based on MRI, I think it depends on the hands of the radiologist as well. Uli, do you want to say anything about that?
I'm probably not the expert for this, and actually my question would also be, but that's a different one. Let's maybe do the choroidal invasion first, but probably better for the panel to discuss this.
Yes. Hervé and Selma, would you like to comment on the MRI imaging? Do you have the same opinion?
Well, I'm not quite sure. We evaluated it once, and in our setting, we have a very good corresponding between MRI and pathology. If you look at more than 3 millimeters. I think it's in this setting, it's perhaps not that important, but what about the children treated with eye preserving therapy? Because there it might be a problem. And we published with our high resolution MRI protocol that we are able to detect it in most of the times.
And from Paris?
I think this case is really interesting because it illustrates the difficulties that might occur with such a optic nerve extension. And in this case, there is invasion of the optic nerve cut section, actually. So this patient might have benefit from probably a neoadjuvant chemotherapy. Probably if this child had been referred to our institution, probably we would prefer to use neoadjuvant chemo in order to avoid this risk, because even with the best hands, sometimes I know it's very difficult to reach a long section of the optic nerve, and sometimes it is only 5 or 6 millimeters, which was probably the case here. And in our institution, we usually prefer to use neoadjuvant treatment each time we have at least 3 millimeters invasion of the optic nerve, in order to avoid this situation, because this child could have avoided radiation therapy, and we know how much it is important at this age to avoid this. So this is the point I wanted to discuss more. About the choroid invasion, my experience is the correlation between imaging and histology is not always perfect, because we have partial volume effects on some areas of the globes, and sometimes it's difficult to be sure. Sometimes it's obvious, and usually it corresponds to a deep choroidal invasion. I think superficial choroidal invasion is not visible by MRI, but deep can be visible. But it depends on the location of this invasion. If it's at the limit of the MR slice, it can be difficult to identify because of partial volume effects. So I am always careful with this diagnosis of choroidal invasion. If it's obvious, I say there is one. If there is no, I wait for the pathology.
Thank you very much. So I think this is really the point for this case, and that's what I see in the questions in the chat as well, is that many participants would have treated with neoadjuvant treatment. And I think it's a very difficult question that is also unanswered scientifically, whether the benefit of the primary histopathology evaluation overweighs here against, on the other hand, is the possibility to reduce the tumor in size and to have a clear margin than if you have a secondary enucleation. And in my opinion, that is unanswered. And I know that many centers have their protocols that they follow. Would anybody like to comment on histopathology results after neoadjuvant chemotherapy from the histopathology panel, please?
There's no consensus on post-chemo changes. So we just report it as it is. We can't use I use the American CAP guidelines to report my retinoblastomas, but it no longer follows through because you have to put post-chemo. So we do see like gliosis if there's regression, and sometimes you see it become a little bit more differentiated. You see a lot of necrosis. So I think amongst us pathologists, we're trying to work together to sort of understand some of the changes. And I think there's some research trying to be done on this to see what are what parameters would be useful for the oncologist on residual disease, because sometimes we see we do see residual disease, but the residual disease can be more differentiated, like more flexo-intestinal rosettes. They don't look as undifferentiated. So what does that mean? Or if there's a lot of calcification, a lot of necrosis, and it's less than 10% of the original tumor, what does that mean? We don't know those questions. So I think we need to work together and sort of like correlate with the outcomes. That's our field from the pathology side. But I think these were excellent slides and that were presented.
Thank you very much for this comment. Nick, am I missing any of the questions in the chat?
Just a couple. One is you showed the streak of tumor almost, or at least going as far as the cut end. Is there a likelihood of skip lesions?
Do you want to comment on that, Victoria?
Yes, I know what you mean. There were spaces in between with no tumor. Yeah, you can where you can see one higher up. And in fact, when I went through the transected the nerve stump as well, I only found tumor cells in one section. And you know, we go through we go through quite shallow levels, and we did lots of levels on this, and it was only in this one section. It was nowhere else. So yeah, I think so. And that raises the concern, doesn't it, for skip lesions further down that are still in the optic nerve remaining.
Can I make a comment, Petra? The cut end disease we've had previously has been a proper chunk of cut end disease, right, like here, right to the cut end of the optic nerve. And that's probably why we made the decision that we'd go for a nucleation, because picking up this streak here, obviously you won't be able to do that with neuroradiology, with MRI scans. But so this is the learning experience for us of this particular case. Obviously, this area was all cut off, and cut with the optic nerve. But it's this streak here that was the issue.
Yeah, the big question is whether you need to know, because many of the centers that use neoadjuvant treatment, they just go depending on the extension of the tumor after the neoadjuvant treatment, and base the indication for radiotherapy on that. I'm honestly not sure. I've seen both ways, and I think we need a prospective study to really clear that. But it is challenging. And I think the question whether you do need radiotherapy in these cases is, even with this histopathology, the big question. And I've seen that Pim de Graaf has joined, and he published on tumor extension of the full optic nerve, so the full width of optic nerve, and because this tumor also gets very close to the subarachnoidal space. Pim, can you comment on this?
Yeah, but actually that was the case report, but it's quite the same case with tumor extension into the up to the subarachnoid space. Also in that case, we didn't found any of tumor cells within that area, but the tumor was clearly infiltrating into the lateral side of the nerve. Eventually, that child relapsed after in between the fourth and fifth course of chemotherapy, if I remember well, adjuvant chemotherapy. So yeah, that's really something that is unresolved currently, because we are always with MRI and pathology studies, we are looking at, do we see enhancement? Okay, does it correlate? Yes or no? We did some work on the depth of invasion with Hervé also. It was difficult to make the correlation, specifically because of these cells that can be a lot more downstream that you see than compared to what you see on the enhancement in MRI. But where we actually never focused really well on is the width of the invasion. It's not resolved yet, although I know that there are multiple cases of this which are probably at a very high risk, higher compared to just post-laminar optic nerve invasion. So the width of the nerve, and yeah, so we published last year on the measurements of the width of the nerve, but more as a factor to predict optic nerve invasion, not exactly to correlate it yet to the extent of the width of the invasion. So that's something that we should do
probably.
Yeah.
So I think I'm very sorry, but I think we have to move on to the second case to allow the same time frame for this second team. Thank you everybody for presenting this case. I think there's a lot of discussion and a lot of parts for this that we have to do more research on to improve our care. Thank you very much. So we move on to the second case, which will be presented by the team from Tel Aviv. And it is Didi Fabian from the ophthalmology side. We've got Shai Schroth from imaging, and Jonathan Weidenfeld from pathology. And then we've got from pediatric oncology, Orit Rubenstein.
Thank you, Petra. Okay, so we'll present a case kind of similar but different. So Shai, you can move to the next slide, please. So this was a 3-year-old female, healthy in general, with the 6 siblings in her family, all are healthy. There was no history of ocular disorders in the family, no retinoblastoma, and her mom noticed a right eye leukocoria and referred for evaluation. So we try to do an ultrasound awake. If that's not possible, we do it under anesthesia. So on ultrasound, the left eye was normal. Here in front of you is the right eye, and what you see here is a hyperechogenic mass with ill-defined borders, mainly inferior and temporal, retinal and subretinal, with hyperechoic foci, but no shadowing posterior to this, so no clear calcifications. The mass go back a slide. Go back to the ultrasound, thanks. So the mass reached that's it. The mass reached the optic disc, and there was subretinal fluid, but the superior retina was attached. I'm only showing one slide, but this is the description. So in conclusion, according to the ultrasonographist said that it looked to her like Coates disease, but she could not rule out retinal blastoma. Okay, next slide. So obviously we decided to do an examination under anesthesia, and it was difficult to see the retinal mass, but the main finding, again, I'm showing only one figure, but the main finding was presence of vitreous seeds, clouds and spheres, and this gave us the diagnosis. You don't see this with Coates disease. The left eye was normal, and the diagnosis made was unilateral sporadic retinal blastoma. We discussed management options. I preferred to do a primary enucleation. The parents wanted to try conservative therapy. We decided to decide after an MRI scan. So let's move on, and then we did the MRI.
Okay, so everyone, so on the MRI, we have on the upper left image, the axial T2 images. We can see there is thickening above the optic disc with another mesh-like lesion in the temporal aspect of the right globe. There is also associated retinal detachment. All these meshes undergoes, especially the thickening above the optic disc, show a mild post-contact enhancement and mild restricted diffusion, as we can see on the bottom right image. On the coronal images, we can definitely appreciate there is a mild dilatation, expansion of the retrobulbar optic nerve on the right compared to the left, associated with a mild enhancement. So these images suggested optic nerve involvement.
So we went with this information, we went back to the family and strongly suggested to do primary enucleation, which we did with an attempt to get the longest optic nerve stump that we could. Next. Okay, Jonathan.
Okay, so we received the size. So there was some mass located mostly in the inferior, around 23 millimeters in the greatest dimension. Most of the tumor was viable, about the 80-85%, around the 10 to 15% was necrotic, and there were no calcifications within the mass. As you
Which
see
correlates to the
on
ultrasound, by the way.
Okay.
The fact that there were no
as you
calcifications, that's interesting. Okay, please.
Yeah. So as you see in the upper part on the top of the images, in the image on the right side, we have also choroidal involvement. There is another picture that we will better see in the choroidal involvement, and there is also, as we see in the right side of the image, there is also involvement of the optic nerve. Invasion into the optic nerve. The anterior part of the eye was free of tumor, without signs of neovascularization, and the sclera, of course, was also free of tumor, with any episcleral also involvement. So next slide, please. So we will center within the optic nerve. So here I know there is a suboptimal section, but we don't see here very obviously the lamina, but we see that there is a retrolaminar involvement of the optic nerve. It involves around 3.94 millimeters of the optic disc, and the rest of the optic disc in the next slide, it's reaching to the margin, to the surgical margin, is free of tumor. There, we did this. Actually, also we tried to get some better section from the optic nerve, but from some reason it was impossible in this case. So we did actually a lot of deeper sections, and there was no evidence of tumor here. And the meninges were also free of tumor. That it's more obvious in the first slide. So the next slides, please. So here's a picture of the choroidal involvement. It's actually a massive involvement. It's more than 8 millimeters in greatest dimension. And the next slide, please. So the tumor, it's actually was grade 2 with many rosettes. There were some foci, some small foci where the tumor was, let's say, less differentiated, was more solid and without the less amount of rosettes. And then I think it's in the next slide, we will see it. It's actually, this is a section, this is a picture from the less differentiated areas, that there are an increased number of mitotic figures here. Most of the tumor was showed mild anaplasia, but here actually it's moderate. I think it's the last slide, if I remember well. Yeah.
Okay, thank you. So personally, I was very satisfied because obviously there are high-risk histopathology features, choroidal involvement and laminar involvement, but there's no cut-in disease. We performed a lumbar puncture, which was negative. Next slide. So we follow a protocol where with these high-risk histopathology features, we give adjuvant chemotherapy, 6 cycles, so from September to January. VC, next slide. And then we did a follow-up MRI. Shai.
Okay, so on the follow-up, we see the right orbit are following enucleation. There is a evolution of early atrophic changes in the right optic nerve stump. There's also a mild associated enhancement, which we often see. There is a image higher, so it's look very similar. And if we go higher, we can see there is a subtle enhancement along the external and optic nerve, which we thought it's probably vascular. There is no expansion of the nerve. There is no signal abnormality within the right optic nerve. If you can look on the coronal images, we can see the same thing. There is a mild, very subtle enhancement along the right, that's external optic nerve, which we thought it's probably vascular. So we didn't think there is no mass within the right orbit, and the nerve look mild atrophic with the changes that we often see following enucleation, except for this mild enhancement, which we thought it's probably vascular or related to the atrophic changes. So the study was reported as no intracranial disease.
Sorry to interrupt, but I think this is a crucial point. Could the other radiologists comment on these images? Do you agree, or you have any further comments? Sam, I have Pim.
I would like to say that what I've told you now is because the next images, the next study probably will show you why we go in retrospect and evaluated these images, because I think in January when the study was performed, we didn't think it's very abnormal, but I will happy to hear.
Petra, I suggest that we have a few more slides to show the follow-up, and then we can go back to all of the images. I agree, this is a crucial point in time. Is that okay?
Sure.
Okay, so next slide. Okay, so that was the January MRI. Then on March 12th, the child started complaining. Go back a slide. Okay, she started complaining of, that's okay, of pain, and the prosthesis did not fit. And on examination, there was no tumor exposure, but the implant was pushed forward. We did a few days later another MRI.
Okay, so in the MRI performed in March, the images are significantly different. We can see on the upper left there is a marked expansion of the nerve stump on the right orbit with a mild enhancement. You can see definitely also on the T2 flare and the T1 post contrast. We can appreciate the marked leptomeningeal enhancement both on the axial T1 images and also on the flare, the post-contrast flare, so significant leptomeningeal disease with a marked expansion of the optic nerve, of the stump of the optic nerve. If we go a bit higher, there is a huge, very large mass, supracellular mass, enhancing mass. You can definitely see on the T1 post contrast, also on the T2 images. Again, the T2. Again, you can appreciate the marked leptomeningeal disease all over infra and supratentorial brain. On the coronal images, we have two coronals. You could see marked expansion of the optic nerve in the right orbit. And you can definitely see the supracellular mass. All these are avidly enhancing, and extensive leptomeningeal disease as well. You can see on these T1 post contrast images.
Thank you. So obviously this was quite a surprise for us. So we immediately asked for a revision of the pathology specimen. Jonathan?
Yeah, so we, upon request, so we actually did the revision. We didn't find any differences in the slides we examined, but we completed more like we did quite a lot of deeper sections, actually with the full block. Afterwards, the paraffin block was already exhausted, and there was any new finding in the deeper sections, no evidence of nerve involvement beyond what we described in the first slide. There was no meningeal involvement. We looked for very carefully for the hemispherial vessels and the vortex veins. If any signs of vascular involvement, there was nothing to report.
Okay, thank you. Orit, treatment?
So, hello. The patient got the treatment due to the RN 0321 protocol. She actually just has completed her induction. She had mild hearing loss that we tried in the mid-induction MRI that we will just see. We saw that she responds very well, but then we tried the third course with carboplatin and not cisplatin, and it did not do a lot of significant response. So we, for the family request, the last course with cisplatin again. And now we're actually waiting for the end of treatment MRI, and hopefully she will be in remission that will allow us to go further for consolidation with the stem cell rescue.
Okay, next slide. Thank you.
So we have MRI on just 2 months ago. I think it's the middle of the treatment. So definitely there's a significant response, but there is still active. These are the post-contrast T2 flare images. We can still see some leptomeningeal disease, mainly in the internal auditory canal on the left, also on the right, also on the subarachnoid space in both hemispheres, but significantly improved compared to prior study. Also, this is the residual supracellular mass. There are other images. We could see that the expansion of the stump of the right optic nerve is much better. There's still some enhancement over there, but it's much smaller compared to prior. And this is a T2, which does not give much information. And you can see the residual supracellular mass, which is still there, but it's much smaller. It's probably some necrotic component, as you can see on this predominantly peripheral enhancement compared to the study before.
Okay, thank you. So we're not very optimistic, and we'll be happy to hear any comments or have questions. Thanks.
Thank you very much for presenting this case. In the interest of time, I'll straight go to my question from before to the 3 experts from the radiology side. So who would like to comment of the 3 of you on the
So Shai, maybe go back to the January slides.
To the first slides.
Can you
Yeah.
explain?
Yeah, this is it. Okay, yeah.
Oh, I put a slide that I think it's in retrospect, it's a bit unusual, but as I said before, it's very, very subtle, and the optic nerve is relatively small, and the right orbit is without any abnormality, intraorbital abnormality, except for the expected post-surgical changes. So I put okay.
Hervé or someone, did you ever see this kind of pattern? I've never seen it with such a discrepancy between the first MRI and then this kind of relapse. And but what I do know is that the pattern that you describe in the prechiasmatic and also in the canal, I've seen that before, but usually it's in continuation with the enhancement coming off of the eye, and then eventually you see in the prechiasmatic space, you can see this surrounding enhancement around the nerve. So that fits, but yeah, it's very difficult to call, of course, with such a skip lesion or whatever it is. Yeah.
Yes,
Okay.
my interpretation of these pictures is that probably the extent of the disease went through the meningeal sheath and not in the nerve itself, because when you showed the pictures afterwards, we see some tumor just around the nerves and not an enlargement of the nerve itself. So I think probably this disease was extending into the meningeal sheath from the beginning, and the optic nerve was cut in a normal area, but probably some cells did seed backwards. So this is the only explanation, but this is a very exceptional situation. I've never seen such a case.
Thanks for your comment. By the way, on histopathology, so the pathologist commented that there was no involvement of the meningeal.
Yes, I understand that, but probably some cells did go in the posterior area.
Whether you have a more aggressive type of tumor here, and there are some questions in the chat about MUC-N amplification. Dr. Anita Shan, would you like to comment on that?
Yes, so I put that in the chat as well. So the question was whether if there's very little calcification, it could be a MIC-N tumor. The MIC-N tumor has a very specific morphology that has the presence of these multiple nucleoli. So if I do see very little calcification, I would sort of like want to look at the sort of morphology of the actual nuclei and the pattern and to look for these nucleoli. I would place more emphasis on that. I just wanted to mention about the optic nerve and whether there's meningeal. So sometimes when we get these optic nerve and we see
Maybe
these,
Shaya, if you can go to the slide, to the magnified slide, so we see.
just of the
This is the
optic nerve.
pathology.
first one.
The first one.
During the
optic nerve.
presentation?
Yeah, to the first
Go back,
pathology slide.
Go back to this and go back to
Pathology
this.
slide, first pathology slide?
This one, yeah.
Yeah.
This.
Yeah. Maybe not this one. Do you have the other one of the optic nerve? There's another one that you showed of the optic nerve.
This one?
The cut end. The cut end.
Oh,
Yeah, so
okay.
sometimes if you see there's a gap and then you see some little blue dots there, we have seen that sometimes occasionally, and a lot of times my general pathologist will ask me, could this be infiltrate, although it's not very obvious. And even for the previous case, but although the previous case from the pathology point of view is quite more obvious because the nuclei is quite bigger, but sometimes you can get these inflammatory infiltrates that cruise along that also mimic very mild, like a very early single cell kind of invasion. So in these cases, sometimes we do perform immunohistochemistry to confirm that they're just inflammatory cells and not just microscopic tumor cells creeping along. Like we do see them sometimes along the meninges, creeping along. The optic nerve actually itself doesn't look so involved. And then we kind of how to report it because it can track far behind, beyond the laminar curvosa. You actually don't see invasion there, but you see it tracking along there. So we always have a difficulty reporting. Is it optic nerve involvement? So we just have to state it as it is and let the oncologist know that if it tracks along, there's a chance that it can go further up to the brain, and they normally do the LP to confirm. But I mean, in challenging cases, sometimes it's very hard just to, based on morphology, we do immunostains just to make sure. And also my advice is usually for these cut ends, I would actually want to see the end of the nerve rather than soft tissue at the end to just make sure that it's really clear in terms of sectioning. I know it's very painful because you really have to go through like 30, 40 levels sometimes. And it's a lot of work for the pathology department. But sometimes it's just something that you have to do. Yeah, so we've done like 50, 60, depending on how.
Can I ask one more question? Sorry to interrupt, because we're of time consent. But can I see again the first MRI and after that the pathology slide? So it was performed in your hospital. Are these images from your center or are these from an outside clinic?
No, this is from our center.
Okay, perfect. Because the other images you showed looked even better. I would like to compliment you on that.
I think it's different machine. This is, I think, is
Yeah,
Siemens. The other is probably Philips.
So that could also, because I think that the first MRI has a 3D T1 after contrast, and it's not the spin echo T1, and that's really a difference. I think that the sensitivity of 3D T1 is much lower to detect optic nerve invasion compared to the 2D sequences. But it's just the thing. It's we don't have evidence for that. It's just a feeling that I have. And so we see that the nerve is a little bit thickened, and also on the pathology slide you see again that it's the entire area of the nerve is involved. Yeah, so you can of course sample multiple sections, but yeah, you can't really rule out that a little bit of cells reached the PIA.
Probably. Another point which is interesting in this case, if you can go back to the first pathology slide, is the shape of the disease, which is a very infiltrative form. And this is a very typical case of diffuse infiltrative retinoblastoma, which we know occur more frequently in older children and which is growing slightly slowly, and maybe could reach the optic nerve even without a very large intraocular mass, and which might lead to such situation.
So Petra, as a pediatric oncologist, would you, in retrospect, would you treat such a case after the first MRI with the neoadjuvant chemotherapy?
This is a really difficult question and touches on the question that we discussed in the first case. I always wonder whether we can really rely on the histopathology after secondary enucleation and about the indication to use radiotherapy or not. And I don't think we have any data for that. So you can only rely on your own center's experience there. And we've got a lot of people joining from countries where we have more advanced disease more commonly. And they have very good experience with neoadjuvant treatment and then enucleation after 3 to 6 cycles of chemotherapy. But in our hands with the ARED 0321, we have a very potent chemotherapy. And I think I always like to know the histopathology, I have to say. And I think we can learn a lot about histopathology, risk factors, tumor risk factors, molecular genetic risk factors. We routinely perform TFF1 staining now to differentiate in between subtype 1 and 2. And also we routinely perform MYC and FISH like a neuroblastoma for all the retinoblastomas that we enucleate. So we do get more information, but at the moment it does not help us yet to guide treatment with that.
Hey.
So I think we have to close. It's a very interesting discussion, and I think we could discuss another hour here. And sorry for all the questions that we missed in the chat. We try to answer most of them by writing, and I think we can address many of the questions that are more general or regarding treatment in one of the next meetings. I hand it over to you, Dee.
Not much to add. It was a great meeting. Thank you, everyone. Thank you, Petra. Thank you, panel. Thank you, presenters and attendees. And see you on our next meeting. Thank you.
Thank you. Very interesting cases.
Thank you very much.
Thank you.
Bye. Thank you.
Whoever is interested to have the recording, just let me know and I'll email it.
Yes, with pleasure. Thank you.
Thanks.